Welcome to Prism Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
Welcome to Prism Rounds, where we break down one study at a time.
It's great to be back.
I can be honest with you. When I saw the stack of papers for this week, this one, it just jumped out at me immediately.
Oh, yeah.
Yeah, I mean, usually we're looking at a new drug trial or maybe some new device that's hitting the market. But today, we are looking at something that feels a bit more foundational.
Foundational is a good word for it.
It's fundamentally about definitions.
Yeah.
It is about the ruler we use to measure reality.
Yeah.
And it turns out the ruler we've been using might be calibrated wrong for, about half the population.
That is a very, very accurate way to frame it. We're looking at a paper that touches on physiology, absolutely, but it is also about policy. It's about history, and at the end of the day, it's about diagnostic precision.
Right.
It's one of those topics that, sleep medicine insiders argue about in the break room or at conferences, but the real-world impact on patients, specifically women, is massive.
It really is. And before we get too deep into the weeds, and believe me, we will get into the weeds, let's just get the specifics on the record. What exactly are we looking at today?
Okay, so we are reviewing a paper titled The Impact of 4% versus 3% Hypopnea Scoring Criteria on Obstructive Sleep Apnea Diagnosis in Women, a scoping review and commentary.
A bit of a mouthful, but the title tells you exactly where the tension lies.
It does. This was published in Sleep Science and Practice, Volume 9, Article 29, in October of 2025. The authors are Krisay Chow, Akram Khan, and Asha Singh.
And one thing I love about this paper, for the listeners who like to dig into the source material themselves, and we know you're out there.
We do.
This is an open access article.
Yes, it is. We always love open access, makes our job easier, and it democratizes the data.
Exactly. Okay, so we have to do our standard housekeeping before we launch. We are walking through this research for educational purposes only. This is a deep dive into the literature. It is not a medical appointment.
Correct. This absolutely does not constitute medical advice. If this conversation triggers some concerns about your own sleep or your breathing or your health, please go see a doctor.
Also, regarding the study itself, we should clarify the methodology right up front. I think that's really important here.
Yes, it's critical to note that this is a scoping review and commentary. The authors did not run a new randomized clinical trial.
So no new patients?
No new patients. They didn't recruit anyone and put them in a lab last week. They went into the existing databases. They pulled all the relevant high-quality literature, and they synthesized it to really map out the evidence.
Which is actually perfect for us because it gives us that bird's eye view of the landscape. And honestly, the landscape they reveal is a bit jagged.
It is.
It brings us right to the core problem, or really the mission of this deep dive. We're talking about obstructive sleep apnea, or OSA. Historically, how have we pictured the classic OSA patient?
Well, historically, and the review points this out immediately, OSA has been viewed as a male disease. When you picture the textbook case, or that old Pickwickian archetype, you're likely picturing a middle-aged man, perhaps with obesity, who snores loudly enough to rattle the windows and has these witnessed pauses in breathing where he gasps for air.
Right, the guy falling asleep mid-sentence at the dinner table.
Precisely. And because that was the archetype, the diagnostic criteria, the rules, the thresholds, the symptoms we look for were largely built around that male phenotype.
So we built a system designed to catch the classic male patient.
We did. The whole diagnostic framework was sort of reverse engineered from that one presentation.
But we know now that women are significantly underdiagnosed.
We do. And the paper argues this isn't just because women aren't coming to the clinic, it's because of a whole mix of things, differences in clinical presentations, so their phenotype, their anatomy, and even sociocultural factors.
Okay, but the smoking gun in this specific review, the thing that decides whether a woman walks out with a diagnosis or is told you're fine, it comes down to a single percentage point.
That's it. It essentially comes down to the definition of a hypopnea.
It does. This is the whole 3% versus 4% debate.
And for anyone listening right now thinking 1%, that sounds like a rounding error, stick with us. Because that 1% is a canyon.
A huge canyon.
Yeah.
It is the central tension of this whole deep dive. To put it simply, we have two different ways of scoring a shallow breath.
Right. One is the 4% criteria, which is older, stricter, and relies heavily on drops in your oxygen levels.
Okay.
The other is the 3% criteria, which is newer, more inclusive, and it accounts for brain awakenings, or what we call EEG arousals.
And the choice between those two rules fundamentally changes the AHI, the apnea-hypopnea index, which is the score that dictates diagnosis.
Correct. And consequently, that score dictates access to care. If you don't hit the number, you don't get the therapy. Simple as that.
The review also touches on the sociocultural and systemic factors briefly. It mentions stigma.
It does, and this is a really interesting point. Women are often reluctant to report snoring. It is often seen as unladylike or embarrassing, whereas for men, it's almost a joke or a badge of honor, Oh, my snoring shook the house last night.
So women might downplay that key symptom in the clinic.
They might, which makes the objective testing, the sleep study itself, even more vital. But there's also a financial layer here. The review explicitly mentions payer implications.
This is a huge piece of the puzzle.
It is. Because in the United States, specifically with Medicare and Medicaid, coverage decisions often still rely on that stricter 4% scoring.
So even if a clinician thinks a patient needs help, and the data is pointing that way under the new rules,
the payer might say, not sick enough, based on the older rule. It creates this huge disconnect between clinical reality and administrative reality.
that sets the stakes perfectly.
Yeah.
We're talking about physiology, but we're also talking about access and equity. So let's unpack the technical side. We need to define our terms so everyone is on the same page. We've got apnea and hypopnea. Apnea is the easy one, right?
Relatively speaking, yes. The definitions here are the rules of the road for sleep scoring. So an apnea is defined as a drop in airflow of 90% or more.
So basically all of it.
Almost all of it, yeah. A 90% or greater drop for at least 10 seconds. Essentially, the patient stops breathing.
It's binary. The air stops moving. It's like a closed gate.
Exactly. Whether there is a desaturation or not, if the airflow is gone for 10 seconds, it is an apnea. It's the door slamming shut. No ambiguity there.
But hypopnea is where all the nuance lies.
This is where the debate lives. A hypopnea is a partial reduction. Specifically, it's a drop in airflow of 30% or more for at least 10 seconds.
Okay, so the air is still moving, but it's restricted. It's like breathing through a collapsed straw. You're pulling, but you aren't getting the full volume of air.
That's a great analogy. You're working harder to get less air. But here is the catch. Just having that drop in airflow isn't enough to count it as an event, is it?
No, absolutely not.
Yeah.
In sleep medicine, the event has to be associated with a consequence.
The consequence.
You need the drop in flow plus a physiological reaction. And this is where the two criteria diverge. This is the heart of the matter.
Okay, let's look at the older one first, the 4% criteria.
So under the 4% criteria, that 30% drop in airflow must be associated with a drop in blood oxygen saturation of 4% or more.
So just to be clear, if my airflow drops by half and I'm struggling to breathe, but my oxygen only drops by 3%, say, from 98% down to 95% under that 4% rule, that event basically didn't happen.
Correct. It is invisible to the AHI. It is not scored. It's a non-event.
Wow. So that rule relies entirely on hypoxia, or lack of oxygen, as the proof of disease.
Yes, that is the only consequence it recognizes. Now compare that to the newer, more inclusive 3% criteria. Here you still have that 30% airflow drop for 10 seconds, but it counts if it's associated with either a drop in oxygen of 3% or more.
Okay, so it's a slightly more sensitive oxygen threshold.
Right, 3 instead of 4. OR, and this is the crucial part, a cortical arousal detected on the EEG.
The arousal, that means the brain woke up.
The brain woke up. Even if the oxygen didn't drop significantly, if the struggle to breathe caused your brain to snap out of deep sleep fragmenting your rest, that counts as a hypopnea under the 3% rule.
So to put it simply, 4% relies on hypoxia, 3% relies on hypoxia or sleep fragmentation.
That is a perfect way to frame it.
Yeah.
The 3% rule acknowledges that waking up to breathe, even without a huge oxygen drop, is just as pathological as dropping your oxygen. It recognizes that sleep fragmentation is, itself, a disease state.
It makes intuitive sense. If your sleep is being shattered 100 times a night, It doesn't really matter to your brain whether your oxygen dropped by 3% or 4%. You're still going to be exhausted.
Exactly. So how do we end up with two sets of rules? Why is this even a debate? The paper goes into the regulatory context a bit.
It does. It traces the evolution of the American Academy of Sleep Medicine, or AASM, guidelines. And if you go back to 2007, the 4% definition was the standard. That was the consensus.
The Dark Ages.
Well, you could say that. It was where the science was at the time. The focus was very much on the cardiovascular consequences, so hypoxia was king. But as we learned more about arousals, sleep fragmentation, neurocognitive outcomes, the science evolved.
So what happened then?
In 2012, and this was carried through to the current third edition in 2023, the ASM updated their stance. They now recommend the 3% definition. They say this is the preferred way to score.
But there is a however. I can hear it coming.
There's always a however. The ASM maintained the 4% definition as an acceptable or optional alternative.
Why? Why leave the old rule as an option if the new rule is better? That seems to invite confusion.
It's a complex question. It often comes down to legacy data, decades of research based on the 4% rule that would be hard to compare, and frankly, payer policies.
Where got money?
The money. Because some major insurers, especially government payers, required the 4% rule for reimbursement, labs needed the option to score that way to get paid, so the ASM left it in as a practical concession. But the result, as the authors of this review point out, is just massive variability.
It creates a lottery. You can go to one sleep lab and get scored with the 3% rule and be diagnosed with moderate OSA. You can go to a lab across town that use the 4% rule, and you're sent home with a clean bill of health.
Exactly. And as this paper argues so compellingly, that variability doesn't affect everyone equally. It specifically and disproportionately impacts women more than men.
Which brings us to the study itself.
Yeah.
Let's look at how they went about proving this. We mentioned this is a scoping review.
Yes. And as we said in the intro, a scoping review is designed to map the available evidence.
So what does that mean in practice?
It's different from, say, a meta-analysis, where you mathematically pool all the raw numbers from every study to get one giant combined effect size.
Right.
Here, they're looking for the themes, the patterns, the gaps in the literature, and the consistency of the findings across different studies. It's more of a qualitative synthesis of the quantitative data.
And they follow the standard guidelines for this kind of work.
They did. They followed the PRISMA guidelines, which is the gold standard for reporting systematic and scoping reviews. It ensures transparency and reproducibility.
Good. So tell us about the search strategy. Where did they look for these papers?
They searched the big databases, PubMed, Medline, and also Google Scholar to catch anything that might have been missed. The search was conducted relatively recently, between September and December of 2024.
And what were they looking for? What were the keywords?
They used terms you'd expect, like hypopnea, scoring criteria, sex differences, gender, 3%, and 4%.
So they were looking for a very specific intersection, articles that directly compare the two criteria and broke down the data by sex.
Exactly. And that filter is so important because there are plenty of papers out there comparing 3%, 4% generally. But finding the ones that specifically tease out the impact on women versus men is much rarer.
So what was the final yield? After they filtered everything, how many studies made the cut?
They found 8 studies in total that met all their inclusion criteria.
Just 8?
Just 8, which in itself is a finding. It highlights how relatively new or, frankly, under-researched this specific gender discrepancy is in the literature.
And what were the characteristics of those 8 studies?
Most of them were retrospective analyses, so they were looking back at existing patient records from sleep labs or clinical cohorts.
Okay, so not prospective trials designed from the ground up to answer this question.
Correct. And they were primarily using data from polysomnography or PSG.
The full in-lab sleep study.
Yes, the gold standard. Though one of the studies did include data from home sleep apnea testing, or HSAT, which becomes very relevant later when we talk about clinical impact.
Okay, let's get to the numbers, the results section. This is where the rubber meets the road. What is the headline statistic? What's the big takeaway?
The headline is startling. Across these 8 different studies, adopting the 3% criteria instead of the 4% criteria increased the OSA diagnosis rates in women by a range of approximately 12.8% to 63%.
63%. That is a massive swing. Let's just sit with that for a second. That means in some patient groups, using the stricter rule is missing more than half the diagnoses in women.
Correct. It's not a subtle effect. And to understand that range, from about 13% to 63%, we need to dive into the specific studies they reviewed, the evidence stack, if you will.
Let's do it. Let's start with the Campos-Rodriguez study from 2016. What did they find?
This was a fascinating study because they analyzed a women-only cohort, so there's no male comparison group. They're just looking at women. They took this group and scored their sleep studies both ways.
Okay.
Under the 4% criteria, the strict 113.9% of these women were classified as having no OSA. Their AHI was less than 5.
Okay, so nearly 14 out of every 100 women in this group were told, "You're fine, go home."
Exactly. But then they rescored those same women using the 3% criteria. And under that rule, the no OSA group dropped from 13.9% all the way down to 1.1%.
Wow. So almost everyone who was considered normal under the old rule actually had the disease under the new rule.
That's right. It represents a 12.8% absolute increase in diagnostic yield. But it wasn't just about finding mild disease. This is a key point. The severity classification changed too.
How so?
The percentage of women classified as having moderate to severe OSA rose from 66.9% to 81.9%.
So it's not just catching the borderline cases. It's taking women who looked mild under one rule and realizing they are actually moderate or even severe under the other.
Precisely. That has huge implications for treatment decisions. Now, let's look at the study that gave us that eye-popping 63% number. That was Johnson et al., published in 2020.
And this one focused on a mild SDB cohort, right? Sleep-disordered breathing.
Yes. They looked at a specific group of patients who were considered to have mild disease, specifically those with an AHI less than 15, but who were symptomatic enough that they were prescribed PP therapy.
So these are people who were clearly suffering. A doctor saw them, heard their symptoms, and wanted to treat them, even if their number was low.
Exactly. Now look at this shift. Under the 4% criteria, a staggering 81.5% of the women in this symptomatic group were technically classified as having no OSA, an AHI less than 5.
Wait, let me process that. So more than 4 out of 5 of these symptomatic women who a doctor wanted to treat technically didn't have sleep apnea according to the 4% rule.
Correct. The rule was telling them they were healthy, even though they felt terrible. But when they applied the 3% criteria to the exact same sleep studies, only 18.5% remained in that no OSA category.
That is a complete flip. That is where the 63% yield increase comes from.
It fundamentally changes the entire clinical picture. Under one rule, the vast majority are healthy. Under the other, the vast majority have a diagnosable, treatable condition. It's a night and day difference.
It effectively inverts the diagnosis. That's
Okay, what about the other studies? There was also one by Hale et al. From 2024. What did they show regarding the gender comparison?
So Hale directly compared men and women. They found that the 4% criteria missed the diagnosis in 30.4% of women. But compare that to men, it only missed 21.7% of men.
So there is a clear gender discrepancy. The stricter rule is almost 10 percentage points worse for women.
Exactly. It quantifies the bias.
Yeah.
And did they see the severity shift too? Yes, they did. The 3% criteria increased the number of women in the moderate to severe category by 23.3%. It went from about 32% of women being moderate to severe up to 55%.
That is a huge portion of patients moving from what some might consider a maybe watch and wait category to a you definitely need treatment category.
Absolutely. Then there's another study listed, Khalid et al., from 2021.
And what did that one find?
Khalid reinforced this significantly. In their cohort, nearly half, 48.9% of the women would have been undiagnosed, completely missed, if they only used the 4% criteria.
Half. 1 out of every 2 women with the disease would have been told they don't have it. Compare that to the men in their study. Only 28.5% of men would have been missed.
So again, the gap is just striking. It's almost double the miss rate for women.
It is. And then there's the One et al. Study, which used the MESA cohort. That's a big, important data set.
The multi-ethnic study of atherosclerosis, yes.
Yeah.
A very well-respected research cohort.
Exactly. They didn't look at diagnostic yield per se, but at the relative increase in the AHI score itself. Using the 3% criteria increased the AHI in women by 83% on average.
An 83% jump in their score.
Yes. Whereas for men, the score only increased by 64%. And they met a really important point. The classic sex difference in AHI, the gap, where men always seem to have higher scores than women, that gap narrows significantly when you use the more inclusive criteria.
Which suggests that maybe women aren't inherently less severe than men. We are just measuring them with a ruler that is designed for men.
That is a very distinct possibility and one this paper strongly supports. And just to round it out, Hirotsu and Habarubio in 2019 found that the 3% criteria increased mild OSA prevalence in women by 13.3%, but only by a measly 1.2% in men.
So for men, changing the rule didn't really change the mild diagnosis bucket much at all. For women, it opened the floodgates.
Exactly. It captured a huge group of women who were previously being ignored.
The paper has a visual for this, right? Figure 1.
Yes, it does. It's a very effective bar chart. It represents the absolute percentage increase in OSA diagnosis for women versus men across several of these key studies.
And if you were to describe that chart to someone, what is the visual trend?
The trend is unmistakable. You have pairs of bars for each study, a bar for women, a bar for men, and in almost every single case, the women bar is consistently and significantly higher than the men bar.
So there's not a one-off finding.
Not at all. In the Johnson study, the women's bar towers at 63%, while the men's is around 60%. But in Khalid, the women's bar is near 49%, while the men's is down at 29%. The visual impact really drives home that this isn't just a scoring issue, it's a sex-specific scoring issue.
Okay, so the data is undeniable. Changing the rule finds more women, the diagnosis rate goes up, the severity goes up. But the big question is why? Why are women so disproportionately affected by this scoring change? Why don't men see the same massive jump?
This brings us to the physiology. We have to look at the fundamental differences in anatomy and the mechanisms of airway collapse between sexes.
Let's start with anatomy. I always think of the airway as a collapsible tube analogy.
Right. And in men, that tube is different. The pharyngeal airway is typically longer, and the soft palate has a larger cross-sectional area. The overall airway volume is greater.
Which sounds protective.
You'd think so, but that longer, floppier structure actually makes them more susceptible to what we call classic complete collapse.
The door slams shut.
Exactly, an apnea. And when that door slams shut for 10, 20, 30 seconds, what happens to your oxygen?
It plummets.
It plummets. That creates a deep, obvious desaturation. So men often trigger that 4% rule easily because their events are catastrophic and hypoxic.
But women's airways are different.
Women tend to have different airway mechanics. They are more prone to partial upper airway obstruction. The door doesn't slam shut. It just gets very, very narrow. It's about resistance, not complete closure.
So it's hard to breathe, but air is still moving. They're fighting for every breath.
Correct. And this leads to very different event characteristics. First, women exhibit more hypopneas than apneas. Their disease is hypopnea dominant. Second, because the obstruction is partial, the oxygen desaturation is often much milder.
So it might drop 2% or 3%, but it might not hit that 4% threshold.
Exactly. They fail the 4% test over and over again, but, and this is the critical piece of the puzzle, their bodies still react to that resistance. Women tend to have a lower arousal threshold in this context.
What does that mean, a lower arousal threshold?
It means their brain is more sensitive to the increased work of breathing. The brain senses the struggle, says, I don't like this, and it pulls them out of deep sleep to restore muscle tone in the airway and open it back up.
So the woman wakes up before her oxygen has a chance to drop by 4%.
You've got it. The arousal is a protective mechanism for the oxygen levels, but it comes at the cost of fragmenting their sleep architecture. And this is the scoring connection.
Let's spell it out.
If you use the 4% criteria, which is desaturation only, you miss these events entirely. You look at the report, you see a flat oxygen line, and you say, nothing happened here. But if you use the 3% criteria, which includes EEG arousals, you see the brain waking up over and over, and you say, that's a hypopnea.
That makes perfect sense. In a way, the 3% rule was basically designed to catch this female phenotype of OSA, even if it wasn't the original intent.
In many ways, yes. It captures the physiological reality of how many women experience airway resistance during sleep. It values sleep fragmentation as a primary outcome.
There's also mention in the review of sleep stages.
Yes, this is another key difference. Women have a much higher prevalence of REM-predominant OSA.
What does that mean?
During REM sleep, our bodies are essentially paralyzed, a state called atonia. This makes the airway muscles even more floppy and collapsible. For many women, their NREM, or non-REM, sleep is relatively stable, but as soon as they hit a REM cycle, their airway starts collapsing and they start having events.
Whereas for men
typically have similar disease severity across both REM and non-REM sleep. So again, men are easier to catch. You can see their disease throughout the night. For women, you might have a low overall AHI if you average it out across the whole night, but they could have incredibly severe disease packed into their REM periods.
And then there are the symptoms. We talked about the classic male presentation, the loud snoring, the witnessed apneas.
Right. Those are loud, obvious, hard to ignore signs. But women present very differently. They are much more likely to report insomnia, fatigue, mood disturbances like depression or anxiety, headaches.
Which sounds like a lot of other things.
Exactly. It sounds like life stress or perimenopause or hormonal changes or a primary mood disorder.
So a primary care doctor might hear those symptoms and think, you're just tired, here's an antidepressant.
Precisely. The clinical picture is much more subtle and nonspecific. And the consequence of that is that because the symptoms are less obvious, the physiological scoring from the sleep test needs to be more sensitive, not less. If the symptoms are vague and the test itself is insensitive to their specific physiology, you have a perfect recipe for a misdiagnosis.
That leads perfectly into the clinical impact section. What does all this mean for the patient and the provider on the ground in the clinic tomorrow?
The biggest risk, obviously, is underreporting. If a sleep lab sends a report to a primary care doctor and it only lists the AHI based on the 4% criteria, that clinician might see a number like 3.5 and say, good news, your sleep study was normal, you don't have apnea.
Case closed. Next patient.
Case closed, even if the patient is exhausted, even if their 3% AHI would have been 15 or 20. The diagnosis is missed entirely, and that patient's suffering is invalidated.
So what is the recommendation from the authors? What's the solution?
The review discusses the value of dual reporting. If feasible, and many labs can do this, the final report should list both the AHI calculated with the 3% rule and the AHI calculated with the 4% rule.
Show your work.
Exactly. Give the clinician the full picture. Let them see. By strict insurance standards, the AHI is 3, but by AASM recommended clinical standards, the AHI is 15. That allows the doctor to have an informed conversation and advocate for their patient.
Now, we mentioned home sleep apnea tests, HSATs, earlier. These are becoming the default first step for many, many people. What is the HSAT trap for women based on this review?
This is a major, major issue. Most standard home tests monitor things like airflow, breathing effort, and oxygen levels, but they lack EEG. They do not monitor brain waves.
So they can't see if you're awake or asleep, and they certainly can't see a brief brain arousal.
Correct. And if you can't see arousals, you cannot score arousal-based hypopneas. Therefore, by their very design, HSATs essentially default to desaturation-only scoring. They are blind to the very events that characterize sleep apnea in so many women.
So if a woman has that classic partial obstruction, high arousal phenotype we just talked about, she takes a home test.
And it comes back negative. It's a false negative. The implication is that HSATs have a significantly higher false negative rate for women than for men.
That is frightening. So if a woman presents with classic symptoms, fatigue, unrefreshing sleep, insomnia, but she gets a negative home test, is that the end of the road?
It absolutely shouldn't be. The guidance and just the logic of it suggests that if clinical suspicion remains high for a woman despite a negative HSAT, a full in-lab PSG is often needed. You need the EEG to truly see the disease.
And finally, let's talk about the money again. The insurance and access gap.
The payer problem. As we noted, Medicare and Medicaid in the U.S. currently and historically have relied on the 4% criteria for CPAP coverage.
So let's talk about that gap patient. Who is that?
The gap patient is the person who is 3% positive but 4% negative. Their AHI is, say, 12 using the 3% rule, but it's only 2 using the 4% rule. Clinically, by the ASM's own recommendation, they have mild OSA, but according to their payer, they do not.
And they are denied coverage for therapy.
Correct. They are in a diagnostic and therapeutic limbo. And the demographics here really matter. The review notes that approximately 25.7% of females over 19 are on Medicare, and another 17.8% are on Medicaid. This isn't a niche problem. This affects a huge swath of the population.
And what about commercial payers? Private insurance?
It's a mixed bag, but many commercial payers have updated their policies and do accept the 3% criteria. So what you have is this massive disparity based on what kind of insurance card you carry in your wallet.
If you have private insurance, your mild sleep apnea gets treated. If you're on Medicaid, it might not.
That is a significant and deeply troubling inequity.
It is. Now, we have to be fair. We are a journal club, so we have to critique the paper we're reviewing too. What are the limitations here? What are the weaknesses of this body of evidence?
The authors are very transparent about this. First, as we said, it's a scoping review of only 8 studies. That is a small number. The evidence base is not as robust as we'd like.
And they were mostly retrospective.
Right. They are looking back at data that was collected for other reasons. We don't have a massive prospective randomized trial designed specifically to test this across thousands of women. Also, a big limitation is that outcomes data is very limited.
Meaning, we know that diagnosing them changes the number, But does treating these specific gap patients actually make them healthier in the long run?
That is the big so what question. And it speaks to the limitations of the AHI itself. We know AHI is an incomplete metric. The review mentions several alternative metrics that might be better markers of disease severity.
Likewise.
Things like the Respiratory Disturbance Index, or RDI, which includes arousals from even more subtle breathing events, or hypoxic burden, which measures the total amount of time spent with low oxygen, not just the number of events, or even things like event duration and the degree of flow limitation.
So it's not just about counting how many times you stop breathing. It's about the total physiological toll of those events.
Exactly. And there was a fascinating insight from that Johnson study regarding this. They found that the women with an AHI less than 5, the ones missed by the 4% criteria, actually had higher rates of anxiety and depression than the women with an AHI greater than 5.
Wait, say that again? The healthier women, by the numbers, had more anxiety and depression.
The women with subthreshold disease. It strongly suggests that this low-level, highly fragmented sleep that isn't being counted as apnea by the 4% rule is still incredibly clinically impactful. It is messing with their mental health, even if it's not dropping their oxygen to a critical level.
That is fascinating. It suggests the mild label might be dangerously misleading.
Very much so. But to get back to the question of treatment benefit for this group, the review does reference one randomized controlled trial, the MERGE trial.
And what did MERGE find?
MERGE looked at treating patients with mild OSA. Overall, they found that CPAP improved sleepiness and quality of life. And in a post-hoc analysis where they looked specifically at the women in the trial, those benefits held up. They got better.
So even for what we're calling mild disease, treatment helped.
Yes. But the author's final call to action is that we need more research exactly like that, but designed prospectively. We need long-term studies on the health outcomes of treating this specific 3% only group of patients. Does it prevent heart attacks? Does it prevent stroke down the line? We suspect it improves quality of life, but we need the hard data on those long-term outcomes.
So bringing it all home, after going through all this, what is the final takeaway?
The takeaway for me is that words and numbers, they really, really matter. The definition we choose to use determines the diagnosis we give. It shapes reality for the patient.
And for women, the choice of 3% spin as 4% isn't just a technicality for sleep nerds to argue about. It's the difference between being seen and being invisible.
It is, at its core, a matter of health equity. Moving toward inclusive, sensitive scoring, as the AASM recommends, is really the only way to ensure that women are not systematically left out of care for a very serious and treatable condition.
If you found this helpful, share with a colleague and send us your next paper.
Goodbye.
Thank you for spending your time with Prism Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.